Hi, Jenny, are you speaking? Jenny, is your audio working? Is your microphone showing a green color? Okay, then, Sarah, is your microphone working?
Can you guys hear me?
Yes, I can hear you. It
Perfect.
seems like Jenny's having some difficulties. Would it be possible for you to introduce yourself?
Absolutely.
Thank you.
Yeah, can I just get going then if that's the case?
Yep, go right ahead.
All right. All right, can you see my screen, Shannon?
Yes, I can see it.
All right, thank you. So my name is Sarah Green. I am a clinical pharmacy specialist at Emory University Hospital in Atlanta, Georgia. And it is my absolute privilege today to present to you all the exciting topic of the top 10 antimicrobial stewardship articles of 2020. I have no relevant conflicts of interest to disclose. Our objectives for the short presentation are to be able to evaluate some of the outcomes of stewardship interventions described in the literature in 2020. And by the end of this presentation, I hope you'll be able to identify some evidence-based stewardship interventions that you can use yourself to enhance your own stewardship program. So to put this all in some context, when we talk about antimicrobial stewardship in the literature, we've seen a dramatic increase in the number of publications that, that have been indexed in PubMed each year. In 2007, when our first IDSA guideline for implementation of a stewardship program was published, only 20 articles this year. Fast forward over a decade to 2020, we now see...
Hi, Sarah. I'm
yes,
sorry to interrupt. Are you advancing your slides?
yes. Are they not working?
Okay. Yeah, I think you might be running into the same issue I had earlier this morning. If you're sharing your PowerPoint, your desktop presentation, that usually goes a lot slower. It's easier just to share your whole screen and then pull your PowerPoint up.
I gotcha. Sorry about that.
That tends to not have any lag.
Let me try that again then.
Yeah, I figured that out a little bit too late this morning.
All right, how about now?
That looks better, yes.
Okay. Thank you for that. Appreciate that. So again, seeing a dramatic increase in the number of stewardship publications indexed each year, close to 1,500 in 2020. Big question is, how do we keep up with all of this literature? Hopefully I can help you with that a little bit today. So looking specifically at the literature that was published in 2020, we definitely still saw several of those traditional antimicrobial stewardship articles published. These are our typical multimodal antimicrobial stewardship programs, usually on the inpatient setting. This may include our penicillin allergy assessments, fluoroquinolone stewardship, carbapenem stewardship, or even a little bit of population-specific stewardship. We also consistently see a lot of literature related to diagnostics. So are we using our tools in the microbiology lab appropriately? And then also the impact of rapid diagnostics on antimicrobial selection and duration. I'm very excited. So we're seeing the literature expand, and now we're seeing more literature on stewardship extenders. So instead of just interventions by our ID physician or our ID pharmacist, we're seeing nurse-driven stewardship, really powerful interventions there, handshake or rounding stewardship with our decentralized teams. Additionally, in 2020, there was so much literature published in the areas of pediatrics and neonatal stewardship, particularly in the area of diagnostics. So applying some of these same interventions to these younger populations. Also exciting to me, more non-acute setting stewardship. So seeing outpatient stewardship programs, stewardship in our emergency departments, urgent care facilities, as well as nursing homes. And then lastly, telemedicine, we're seeing increases in that area as well. Right now, this is typically large health systems employing their largest facilities to support kind of the smaller ones. But I think after the year that we all had, we're going to see more related to telemedicine stewardship in the future. All right, and with that brief background, I'm going to get right into my top 10 stewardship articles of 2020. These articles all highlight a defined stewardship intervention, and they're selected either because they were novel, had a lot of impact, or just had a really strong study design. So to kick us off, this is again, falls into that traditional stewardship bucket. This is the penicillin allergy delabeling program. It's a multi-center whole of hospital health services intervention and comparative effectiveness study published in Clinical Infectious Diseases by Chua and colleagues. To give you an overview of this study, again, prospective, multi-center, they were actually looking at the impact of a previously validated antibiotic allergy assessment tool. One of the reasons why I like this study so much is they took this validated tool and they actually trained more than just the primary team taking care of the patient to use this tool. So these detailed allergy assessments were performed by nursing, they were performed by pharmacy, and we were able to employ more people to work on the stewardship initiative. Once they completed the allergy assessment, they actually stratified patients in either low risk for having a true penicillin allergy or high risk for a true antibiotic allergy. And based on that stratification, they either directly delabeled the patient, offered them a direct oral penicillin challenge, or for those high-risk patients, referred them to the outpatient setting for assessment. And they had strong outcomes with this. So they looked at about 1,200 they performed these histories on about 1,200 patients, and about a third of those were successfully delabeled in the inpatient setting. And this was kind of half and half. So in general, these were low risk allergy, or these patients were deemed low risk for true penicillin allergy, and they were actually able to be directly delabeled without any further intervention. There were some patients that, again, relatively low risk, who after receiving an oral penicillin challenge were also able to be delabeled. And then they did a cost effectiveness analysis. And so they actually determined that to delabel 355 patients on the inpatient setting, it cost about $7,000 as compared to over $60,000 if they had to refer the patients to the outpatient setting. And so again, what I love about this study is this is kind of an all hands on deck approach to penicillin allergy delabeling. We took our tool, we trained nursing and pharmacy partners, and we were very successful in getting these allergies off the patient profile. Additionally, this highlights, again, because there were so many low risk penicillin allergies noted, just that in general in our population, there's a significant over documentation of penicillin allergy, and we can definitely make interventions to get that modified. Moving on to number 2, I'm still in the inpatient setting, and still in clinical infectious diseases. This is improving decision-making in empiric antibiotic selection for gram-negative bacteremia by Ellickson and colleagues. There are several similar concepts in the literature developing models for empiric selection of antibiotics. So here we are balancing the need to make sure that our patients are on active therapy with the need to minimize overuse of broad spectrum antimicrobials. And so that's what this group did. This was a quasi-experimental study using these predictive models specific to gram-negative bacteremia. They developed and validated their own model. And once that was in place, it was actually a pharmacist-run initiative. So future patients that were admitted with gram-negative bacteremia, depending on their QSOFA score, were either recommended an antibiotic with a 90% chance of coverage if they had a QSOFA greater than 3, or an 80% chance of coverage for our more clinically stable patients. And what they found, even in selecting these more narrow therapies, was that patients in the intervention group were more likely to have more narrow therapy, but there was no difference in adequate therapy at the time of final cultures. And so even though we're starting more narrow, we're still picking appropriate therapy. And they saw no difference in clinical outcomes, so no difference in time to adequate therapy, length of stay, or mortality. The reason why I highlighted this study, again, this is a really awesome use of predictive modeling to help us select empiric therapy. But I really like the fact that they stratified by Q-SOFA score to help select the most narrow therapy for their patients while maintaining appropriate therapy for patients with sepsis. Moving on to article number 3, again in clinical infectious disease. This was a randomized controlled trial of an electronic clinical decision support tool for inpatient antimicrobial stewardship. And so this trial was a multi-center randomized controlled crossover trial that utilized or evaluated the impact of a weighted incidence syndromic combination antibiogram on patient outcomes. And if you look at that, if you're like me, you are probably asking yourself, Sarah, what in the world is a WSCA? And I will get to that in just a moment. But this was another tool that was utilized to help select empiric therapy. And so to develop this tool, they put 3 years of microdata into the model. And then when they had future patients with the target infections, an ASP physician actually made recommendations to the primary team based on this model. In general, these infections were intra-abdominal, UTI, CAP, or cellulitis. And overall, they found no difference in their primary outcomes of overall length of stay or 30-day mortality. But they did start to see some differentiation in their subgroups, so shorter length of stay for cellulitis and decreased 30-day mortality for CAP. Regardless of the kind of indeterminate outcomes, I pulled this article because, again, I did not know what a WSCA was. And so when you think about our antibiogram, this is a tool that basically says if you have this bug, this is the % chance of coverage by any given drug. This WSCA tool is amazing. They basically took UTI, for example. They selected all of the bugs that might be involved in a urinary tract infection and gave you the % coverage for that entire infection. And so I feel like this actually makes a more useful antibiogram tool for our providers who want to treat somebody with UTI, want to treat somebody with CAP, and might not know what organism we necessarily need to cover. I feel like this would be a relatively straightforward intervention for you to implement, and highly recommend pulling this article and learning more about WSCA if you can. All right, so moving away from clinical infectious disease, this is the impact of an antimicrobial stewardship program pharmacist during microbiology rounds. This was a single center retrospective descriptive study, looked at both the inpatient and ambulatory culture space, and was unique because this ASP pharmacist focused just on requests for additional susceptibility testing. So those culture results that either we don't report sensitivities because we don't think of them as a true pathogen, or the physician or provider wanted additional testing in order to use a non-preferred agent. This study targeted specifically those requests for additional testing. So basically, every day or 3 times a week during micro rounds, the ASP pharmacists reviewed these requests for additional testing, and they provided feedback to the requesting provider as needed. So that feedback was either, hey, this is usually a contaminant, here's this oral option that you could use, or some piece of education like that. And what they found with this, again, fairly straightforward recommendation was that they were primarily looking at urine cultures, and they were able to avoid unnecessary susceptibility testing in almost half of the cases. Additionally, they decreased their treatment of contamination rates as well. And so I highlighted this article because, one, the microbiology rounds were actually done by telephone. I think that the telephonic nature of this intervention makes this more accessible, depending on whether or not your microlab is on site, depending on if you have time to attend a full plate rounds, or even if those plate rounds exist. And two, it simplifies. So we're not looking at all culture results. We're just looking at the ones with additional susceptibility requests. And so small, straightforward, but still very impactful. Moving on to number 5, this was published in Clinical Microbiology and Infection. This is looking specifically at our inpatient kidney transplant population, so antibiotics versus no therapy in kidney transplant recipients with asymptomatic bacteriuria. This was a multi-center randomized open label superiority trial, so really strong study design, specifically in kidney transplant recipients with asymptomatic bacteria and more than 2 months post-transplant. And to put some context for this, actually there was a study that showed that about 70% of providers who manage kidney transplant patients actually do routine screening for asymptomatic bacteria or for bacteriuria. And this isn't in line with current consensus guidelines. So they say avoid using screening and treating bacteria in this patient population. So this study looked at patients in their follow-up clinic that were already undergoing lifelong routine screening. Asymptomatic bacteria was defined by the standard definition, and patients were randomized 1-to-1 to antibiotics or no treatment. We had fantastic results with this study. So there was no difference in the incidence of symptomatic UTI. So the concern that presence of bacteria in the urine would lead to an acute infection or impact of the graft was not validated. And you can see that at the next point. So 2% versus 3%, no difference in graft loss. Similarly, no difference in incidence of pyelonephritis. But what we did find is those patients who received an antimicrobial, there were significant increases in their colonization with resistant bacteria after that antibiotic treatment. I selected this article because I have found that it's very difficult sometimes to be an effective steward in these sensitive patient populations. So populations where the consequences of, trial and error may result to really profound consequences for them. So highlighting that, and then additionally, the strength of the study overall. All right, so we're starting to head into the outpatient setting, looking at decreased overall and inappropriate antibiotic prescribing in a VA hospital emergency department following a peer comparison-based stewardship intervention published in Antimicrobial Agents and Chemotherapy. So this was a prospective observational cohort study, and they were looking at applying the kind of one of the traditional stewardship methods of peer comparison, specifically to patients discharged with a prescription for an antibiotic from the emergency department. Their intervention was very straightforward. So they received, our ID providers received a 30-minute educational module delivered by an ID physician. And the ED physicians after that module also received monthly emails with de-identified bar graphs comparing their antibiotic use to that of their peers. And so this simple, straightforward intervention yielded a decrease in 10 prescriptions per 1,000 ED visits per month. So improved result there, and also decreased the rate of unnecessary antibiotic prescriptions from 55% down to 39%. I highlight this study. I love seeing kind of tried and true stewardship methods applied to unique places. And so this is another example of where peer comparison worked for our emergency department providers. For number 7, we are moving to a family medicine resident clinic to look at outcomes of an ambulatory care pharmacist-led antimicrobial stewardship program published in Infection Control and Hospital Epidemiology. This was a retrospective quasi-experimental study in a single family medicine resident clinic, and they looked at the impact of a multifaceted outpatient stewardship program, so seeing more data in the outpatient stewardship arena. The stewardship program consisted of a three-pronged intervention by two ambulatory care pharmacists. These ambulatory care pharmacists had additional support from the ID pharmacist and an ID physician if needed, but in general, they provided educational sessions to the family medicine residents, provided local treatment guideline pocket cards, and gave biweekly post-prescription audit and feedback. And what's really unique about this feedback is they had actually done a previous pilot study evaluating what type of feedback was most effective. And so based on that pilot study, these family medicine residents received positive feedback about what they had done well in their prescribing, with some opportunities for improvement. So utilizing positive feedback for our providers. They saw a significant increase in overall concordance with their guideline recommendations across our general outpatient ID disease states. So upper respiratory infection, skin and soft tissue infection, and UTI. And this include increases in appropriate agent, dose, and duration. Highlighting this article, it shows a effective, straightforward outpatient stewardship program, and I really appreciated their utilization and study of the best type of feedback and using positive feedback for our providers. For number 8, we're actually looking at nursing homes. So this is a multifaceted antimicrobial stewardship program for the treatment of uncomplicated cystitis. This is a multi-center randomized controlled cohort study, not only of one nursing home facility, but of a network of 25 nursing home facilities. So kudos for them for that. This was a quality improvement initiative targeting uncomplicated cystitis. This initiative consisted of education for nurses, pharmacists, and prescribers at the nursing home. So again, an all hands on deck approach. They provided webinars, pocket cards, clinical vignettes, monthly coaching calls, and quarterly feedback reports. And what they found was that these education and support initiatives did decrease antimicrobial use for uncomplicated cystitis, decreased antibiotic use for any UTI, reduced rates of C. diff, and we know how important that is everywhere, including the nursing home, and found no difference in all-cause hospitalization or death. I highlight this study. It can be difficult to do stewardship in kind of novel places like nursing homes. Uncomplicated cystitis is definitely a great target. We see a ton of antibiotic prescribing in nursing home facilities for this indication. And the authors not only targeted this, but they did it across a network of 25 facilities. So really impressive there. For number 9, we are looking at the impact of effectiveness and safety of mandatory antimicrobial indications and durations, and a pharmacist-driven 48-hour timeout in a pediatric hospital. And this was published in the American Journal of Health System Pharmacy. So this was a single-center retrospective pre-post study evaluating the impact of not only mandatory antimicrobial indications and durations, but also 48-hour timeout. And so this intervention was unique because the stewardship team actually utilized their decentralized pharmacists to do this 48-hour timeout. And so in making this whole intervention, they did find significant decreases for several antibiotic classes. You can see those listed there. But what's kind of more important is that these decreases were in the setting of no additional interventions by the ASP team themselves. So no additional work, but still seeing decreases in antibiotic use. That 48-hour timeout, a lot of institutions worry about antibiotics falling off unnecessarily. So in 7% of reviews, we actually did have to reorder antibiotics. But overall, there was a less than 1% chance of actually kind of missing a dose unintentionally. I highlight this article because it's a multifaceted stewardship approach, kind of a big rollout, multiple interventions in a pediatric setting. And it was really a good utilization of the entire team to perform stewardship, as reflected by the change in antibiotic use without the change in ASP intervention rate. All right, and last but absolutely not least, I'm so excited about this study. This was the impact of a comprehensive antimicrobial stewardship program on institutional burden of antimicrobial resistance. This was a 14-year controlled interrupted time series study. So when we look at antimicrobial stewardship, we've seen a lot of evidence in the literature of the impact of antimicrobial stewardship programs on antibiotic utilization. But in terms of actually being able to demonstrate our impact on antimicrobial resistance, we don't have as much clear-cut data. And so this 14-year controlled interrupted time series sought to do just that. This program had a robust ASP. They did several interventions, including service line education, implemented guidelines, formulary restrictions, etc. And they saw, like other programs, significant reductions in antibiotic use. But what is even more profound was their reductions in institutional antimicrobial resistance. And so resistance rates overall decreased by 9%, and our hospital-acquired MDROs decreased by 13%. And this was in the setting of their control group being community-acquired resistance. So over that same time period, they saw increases in community-acquired resistance of 40% and an increase in MDROs by 68%. I highlight this study again because we don't have a ton of definitive data showing the role or the impact of stewardship programs on antimicrobial resistance. I think this was really well done. So that is it for me. Hopefully you have identified a study that you can take back and apply to your own stewardship programs. I went through that pretty quickly, so if you have any questions, feel free to reach out to me. I'm going to give it back to our moderators.
Jenny, are you speaking? While we wait for her to figure out her microphone issues, Sarah, if you can you see the chat on the side? I think you have a couple of questions.
I am. Yep. So one of our infection control nurses, Kim Barrett, asked regarding our penicillin allergies, are we referring to a recommended routine penicillin screening for reevaluating a patient for a continued true allergy? Would this depend on how long ago allergy was first described, age, and description? Thank you. Yes, Kim. So that study was an example of an institution that had taken all of those factors that you mentioned. So time since the reaction, what that reaction actually was, what agent they received, had they received any agents that were similar structurally and not had a reaction. That whole part of taking a patient history, doing that full allergy assessment. And so they had actually created a validated allergy assessment tool in order to do these histories. And they rolled out that tool, again, not only to the primary team taking care of it, but to everybody. So nurses, pharmacists, everyone was able to, evaluate a patient with a penicillin allergy and delabel it if appropriate. Thanks, number 7, for the acknowledgement from Lindsay Westerhoff. Thank you for that excellent work. That was a great study. That's wonderful. That made my day. See, I've got one more minute. Carol Ricken, in the renal transplant study related to individuals with recent transplants or throughout the course of an individual's post-transplant life. That's a great question. So they started with patients 2 months after their renal transplant who were undergoing, they would receive screening for the rest of their lives. That was the practice at the clinic that they targeted. But they looked at patients who were at least 2 months post-transplant, and they followed them for a year after their transplant. That's a great question. All right.
So we are at the end of this session. If there's any more questions, I have changed the settings from this morning. It won't cut off directly at the time. Learned from Dr. Zike, unfortunately, being cut off. but it is time for the lunch hour. So feel free to go ahead and get lunch. But there's also some presentations that are going on right now over in the exhibitors tab. And I can share my screen and show you how to get there. All right, I'll share right now. All right, can you guys see my screen? Sarah, can you, I'm not sure if Jenny figured out her microphone
Yes,
yet.
we can. Thank you.
Okay, so if you just go over on the left-hand toolbar to the exhibitors, there you can see our posters. And the green dot means that they are currently available to speak. So Travis Nielsen is available. You can download his poster here, or you can just look at this picture. It should pop up. It's a little hard to read, so you might want to download the PDF. You can also chat one-on-one with him, meet now with him. That's this little green camera icon. And just to hear more about the work he's done. So feel free while you're eating lunch, or if you get a second, to go over to the exhibitors tab and check out all of our awesome poster presenters today. All right, thank you guys so much for joining. We're going to go have a quick break. I'm going to go check out some of those posters, and then we will reconvene for the afternoon breakout sessions.